Welcome. In the previous two sessions, we had discussed about congenital lacrimal disorders and acquired lacrimal drainage obstruction. In this session, we are going to discuss the other forms of acquired lacrimal drainage disorders such as trauma, infection, and neoplasia, and most of these entities are also associated with obstruction of lacrimal drainage. We'll also discuss in this session about lacrimal plugs used for dry eye. Canalicular trauma can occur due to direct injury to the canalicular area or avulsion injury when the eyelid is pulled laterally. An avulsion injury of the canaliculus is associated with tears in the medial canthal tendon, with which the canaliculi are intimately associated. Early exploration and repair of an injured canaliculus is recommended. This is because it has been seen that primary repair has a much higher success rate than secondary reconstruction in achieving patency of the traumatized canaliculus. First, the lacerated or the cut ends of the injured canaliculus are identified by irrigation with air or fluorescence or by probing. The lateral cut end is explored from the puncta of the injured eyelid, and the medial cut end is explored from the puncta of the opposite uninjured eyelid. Identifying the medial cut end may be difficult when the laceration is medially located near the nose, as the canaliculus lies behind the anterior arm of the medial canthal tendon in this area. Following identification of the lacerated or cut ends of the injured canaliculus, the injured canaliculus or both canaliculi are stented. Stenting maintains canalicular patency by preventing stricture formation. The stent is placed under traction to approximate the cut ends of the canaliculus. Suturing the pericanalicular soft tissue, the medial canthal tendon tear and eyelid margin tear reduces tension between the cut ends. The stent is left in place for at least 3 months before removal. However, earlier removal may be required if there is ocular irritation, cheese wearing at the punctum, infection, inflammation, and pyogenic granuloma formation due to the stent. Lacrimal sac and nasolacrimal duct can be injured by direct laceration, fracture of adjacent bones, or iatrogenically during a rhinoplasty or an endoscopic sinus procedure. Primary repair of such a trauma is recommended, which may involve fracture reduction, soft tissue repair, and intubation of the entire lacrimal drainage apparatus. If secondary repair becomes necessary, a DCR or a CDCR procedure may be required, but this should be done only after complete healing of the traumatized tissues. Inflammatory non-infectious Dacryoadenitis we have discussed in session 8 of the current Oculoplasty section, and infectious Dacryoadenitis is usually bacterial but rare, and it may occur from infection of adjacent tissues, from trauma, or hematogenously. Other etiologic agents which can affect the lacrimal gland include tuberculosis and Epstein-Barr virus. Clinical features of Dacryoadenitis includes pain and swelling in the lacrimal gland area in the superotemporal portion of the orbit, and infectious Dacryoadenitis may show pus extruding out of the openings of the lacrimal ductules near the lateral portion of the superior conjunctival fornix. For non-suppurative cases of infectious Dacryoadenitis, oral antibiotics are administered, but when there is abscess formation, drainage of the abscess may be required. Canaliculitis can be caused by bacteria, viruses, and fungus, but is most commonly due to Actinomyces israeli, and this is very important to remember. Canaliculitis can also be secondary to dacryocystitis or retained lacrimal plugs in the canaliculus. Clinical features of canaliculitis includes epiphora and discharge. The punctal opening appears erythematous and enlarged, and this is called pouting of the punctum. Follicular conjunctivitis can be present in the medial canthal area, and purulent discharge can be expressed through the puncta by compressing the involved canaliculus with a cotton-tipped applicator, as seen in this picture. Eradicating canalicular infection is difficult, and conservative management options include warm compress, digital massage, and topical and systemic antibiotics, but most cases of canaliculitis will require punctal curettage or canalicular incision called canaliculotomy to remove the debris and the foreign body from the canaliculus. The canaliculus can be irrigated with povidone iodine or penicillin, and the incisions are left open to heal by secondary intention without lacrimal intubation. Dacryocystitis or infection of the lacrimal sac results from stasis of tears in the lacrimal sac due to a complete obstruction of the nasolacrimal duct. And dacryocystitis can occur in an acute form or a chronic form. Acute dacryocystitis presents with pain which may vary from mild to very severe in nature. We will find a tender swelling of the lacrimal sac with edema and erythema of the overlying skin and soft tissues. Reflux upon digital massage is usually not present and the sac is non-reducible in acute dacryocystitis. This is because of acute expansion of the lacrimal sac laterally in acute dacryocystitis, which kinks and blocks the common canaliculus, preventing reflux. Sequelae of acute dacryocystitis includes conjunctivitis, orbital or facial cellulitis, lacrimal abscess formation, or acute dacryocystitis may partially resolve to a chronic dacryocystitis, also called a mucocele. In acute dacryocystitis, syringing or probing should not be done during the active phase of infection because it is very painful and may create false passages. Oral antibiotics are recommended in most cases of acute dacryocystitis because topical antibiotics have little effect. However, in severe cases or in those with cellulitis, intravenous antibiotics will be required. Patients with acute dacryocystitis ultimately requires a DCR procedure. However, an external DCR can be done only after resolution of infection, whereas an endonasal DCR is possible during the phase of active infection, and this is very important to remember. If there is lacrimal abscess formation, lacrimal sac may be incised and drained through a cruciate incision. Chronic dacryocystitis is a low-grade smoldering infection which may or may not be preceded by an episode of acute dacryocystitis. Clinical features of chronic dacryocystitis includes absence of pain, presence of epiphora and discharge, swelling of the lacrimal sac, and reflux of mucus or mucopurulent discharge through the punctum upon digital compression of the lacrimal sac area. Chronic dacryocystitis requires DCR, which relieves the epiphora and the mucoid discharge, and we have discussed the technique of DCR in the previous session. When chronic dacryocystitis coexists with a condition such as cataract, which requires intraocular surgery, dacryocystorainostomy must always be done several weeks before the intraocular procedure, and this is very important to remember. We have discussed lacrimal gland tumors in session 12 of the current oculoplasty section. Tumors involving the lacrimal drainage pathways can be primary tumors of the lacrimal sac, secondary involvement from tumors in adjacent tissues, among which basal cell carcinoma or squamous cell carcinoma of the eyelid are the most common. Metastatic tumors from distant sites may also involve the lacrimal drainage pathway. 45% of primary lacrimal sac tumors are benign and 55% are malignant. Squamous papilloma and squamous cell carcinoma are the most common forms of benign and malignant primary lacrimal sac tumors. Squamous papilloma of lacrimal sac is mostly inverted in nature, leading to incomplete resection with a future risk of recurrence with malignant transformation. Clinical features of lacrimal sac tumors include epiphora or discharge, but these may be absent in the early stage. There can be blood in the tears called hemolacrima, and there will be swelling of the lacrimal gland, which characteristically extends above the level of the medial canthal tendon, in contrast to what we find in chronic dacryocystitis, where the swelling of the lacrimal sac is restricted to below the level of the medial canthal tendon. There can be telangiectasia and ulceration of the overlying skin, and there can be evidence of spread to nearby tissues and regional lymph nodes. When neoplastic involvement of lacrimal sac is suspected, imaging is required with CT scan and or MRI, and the CT scan photograph shows a tumor involving the lacrimal sac area. Benign tumors of the lacrimal sac are resected by dacryocystectomy, in which only the lacrimal sac is removed. But for malignant tumors of the lacrimal sac area, Dacryocystitis is combined with removal of adjacent bones of the nose and or maxilla. If the orbit is involved, exenteration will also be required. Radiation therapy is recommended for lymphomas, for adjuvant therapy following surgical removal of epithelial tumors, and for unresectable tumors in the lacrimal sac area. Therapeutic closure of lacrimal drainage pathways is a treatment option for recalcitrant severe dry eye, and punctal plugs can be used for this purpose. Dissolvable collagen punctal plugs, or more commonly silicone punctal plugs as shown here in this photograph, may be used. Silicone plugs can cause ocular irritation or an inflammatory reaction leading to pyogenic granuloma formation. Silicone plugs may be extruded or lost, and silicone plugs can migrate into the canaliculus and lacrimal sac, potentially causing infection. Extrusion and migration can be prevented by proper sizing of the silicone plug. Intracanalicular plugs are not recommended for therapeutic closure of the lacrimal drainage pathway. Apart from punctal plugs, surgical closure of the lacrimal drainage pathway is also feasible, but prior to a surgical closure, temporary punctal closure must be performed with punctal plugs to exclude the occurrence of post-occlusion epiphora before a definitive surgical closure is done. One puncta is first closed surgically and the patient observed for the occurrence of epiphora before closing the opposite punctum surgically. If there is epiphora following surgical closure, the patient will require a CDCR to control the epiphora. Options for surgical closure of lacrimal drainage pathways include thermal occlusion, in which the punctum and the adjacent canaliculus is cauterized. The ampulla, or the proximal vertical portion of the canaliculus, can be excised along with the punctum with or without an overlying conjunctival graft, and this procedure of excision of the ampulla with the punctum is called ampullectomy. Excision of the canaliculus with the cut ends of the canaliculus rotated away from each other is also an option. Thank you for listening.